Hello, my name is Dr. Brian McClelland, and today I would like to take an article on nutrition and wound healing. This is a fairly long and involved article, so I'm going to break it up into two separate episodes that we'll do, we'll begin now. The author of this is Dr. Mary Mazzotta. She's a professor of biochemistry department of basic sciences in San Francisco. The source is the Journal of American Podiatry Medical Association, volume 84, number 9, pages 456 to 462. The evidence of significant malnutrition has been found in specific groups, including alcoholics, the poor, the elderly, and chronically ill. Further, protein malnutrition was detected in up to 25% of all hospitalized patients, while 15% of general surgery patients exhibited moderate to severe protein malnutrition. And this is in the United States. Inadequate nutrition delays wound healing, decreases immunocompetence, or increases susceptibility to infection, and causes and results in a longer hospital stay, and increases both morbidity and mortality from surgical wounds. So let's start with protein. The recommended daily allowance for protein intake for healthy individuals is 0.8 grams per kilogram of body weight. To support wound healing, the U.S. RDA goes up to 2 to 4 grams per kg per day. Normal serum albumin concentration is 4 grams per deciliter. Some common indicators of protein malnutrition clinically are dry, flaky skin and peripheral edema. The condition of the hair may be another outward sign of protein deficiency and protein malnutrition. The hair can be dyspigmented, easily plucked, and sparse. Muscular cramps and muscle wasting also occur. In a protein-deprived patient, the inflammatory stage of wound healing is prolonged. Angiogenesis and wound remodeling are also impaired. The best sources of balanced protein are meat, dairy products, and eggs. When treating protein malnutrition, a preoperative supplementation has been more effective than postoperative. As little as 1 week of preoperative protein supplementation improves wound healing. For instance, supplements of cysteine and methionine, which are sulfa-containing amino acids, decrease the amount of protein destroyed in the inflammatory stages, and in turn decrease the prolongation or the length of time of the inflammatory stage. The amino acid arginine is converted by mononucleosides or monocytes into nitrous oxide, which is then used to kill bacteria. So arginine supplements enhance the development of cytotoxic T cells, stimulate lymphocyte proliferation by activating guanylate cyclase, and increase the resistance to infection. So protein has a number of benefits in a surgical patient. Vitamin A. Vitamin A deficiency is asymptomatic. In general, vitamin A stimulates the immune response. Vitamin A deficiency is associated with a marked reduction in antibody response, so the immune response stimulates the autobody response. Vitamin A stimulates the immune response since the antibody response and cytokine production, and some mediated cytotoxicity and the maintenance of an intact epithelial barrier are all affected by vitamin A deficiency. Vitamin A enhances the early inflammatory phases, increasing the number of monocytes and macrophages. On the other hand, phagocytosis decreases with the resultant accumulation of pus and debris in vitamin A deficiency. Vitamin A also stimulates fibroblast differentiation and collagen deposition during the proliferation stage, increasing the bursting strength of the wound. Postoperative supplements for vitamin A for 7 days increases collagen synthesis and the bursting strength of scar tissue and increases lymphocyte activation. Vitamin A exhibits anti-steroid activity. Topical vitamin A, so on the wound, increases epithelialization of the wound and improves the cosmetic appearance of scars. Dietary sources of vitamin A include liver, dairy products, egg yolk, yellow and dark leafy green vegetables, and deep yellow or orange fruit, carrots. Zinc. This is the last one that we'll cover for today. Zinc is probably one of the oldest agents used to promote wound healing. It was used topically as a calamine lotion as far as back as 1500 BC by the Egyptians. That's like 3,500 plus years. There are approximately 200 zinc requiring enzymes in the body. Marginal zinc deficiency is actually quite common in the United States, especially among the poor. Pregnant and breastfeeding women are also at risk of zinc deficiency. The soil is poor in zinc in 32 states, and the produce raised in those areas reflects this deficiency. Vegetarians are at risk of a zinc deficiency because the cereal grains are low in zinc and more is removed during the milling process. Although zinc may be concentrated in the skin, hair, and nails, it's not readily stored and it can be readily lost from the body. Certain conditions can also produce deficiency, such as surgery, stress, sepsis, and diarrhea. Some medications can also induce a zinc deficiency. Diuretics and antimetabolites are two examples. Also, TPN, or total parenteral nutrition, which is being fed through an IV, generally provides little zinc. There is some difficulty in establishing whether a true zinc deficiency exists. In fact, the best method for assessing zinc deficiency is controversial. In zinc deficiency, there is a delayed closure of wounds and ulcers. The collagen produced has a decreased tensile strength. There is a lymphocytopenia, decreased in lymphocytes, and in your natural T killer cells, and a decrease in the size of the thymus, and an increased susceptibility to recurring infections and poor wound healing as a result. Topical zinc inhibits bacterial growth. Zinc oxide is incorporated into dental cement because of this antibacterial component. I knew I liked this lady. Zinc deficient adults generally develop skin rashes. They also may experience disturbances in smell, taste, and vision. Topical administration of zinc chloride as a spray or ointment decreases the size of a wound and shortens the healing time and produces less dehiscences. So next time we're going to cover vitamin C, vitamin E, and iron. Thanks for tuning in.